Let me wait.
Good afternoon. We are waiting one more minute, but in the meantime, I remind you that you should mute your microphones. And also I remind you that the webinar is being recorded. Okay, Margot, should we wait one more minute or should we start?
Just one more minute and then it should do. I think just start, Javier.
Okay, so welcome everyone to this webinar. My name is Javier Jerez, and I will be coordinating this webinar. I would like to thank you, Margot and Marilyn, for organizing this webinar from the World Federation of Patients with Incontinence. So today we will have like 4 speakers. Myself, I will be starting introducing the topic. Then is Adrian Walk and William Gibson chatting about care delivery in care homes. Finally, Hannelore Strauban from KU Leuven. She will be chatting about a new project, which is called Procon in nursing homes. And in the last part of the webinar, we will have some space for questions and answers. So from now, feel free to use the chat to text your questions. And I also remind you that to mute your microphones, and the webinar is being recorded. Okay, so let's start with the first presentation. There is one microphone activated from Mauro. Can you please mute it? Okay, so I'm going to present this new project, which is called Coco Bladder. Coco Bladder stands for Keep Up Your Bladder Health, co-creating and testing a self-management technological solution for aging well. My name is Javier Jerez, and I'm the principal investigator of this project. We have a partnership of 3 countries in Coco Bladder project. So we have partners from Spain, University of Vic, the M3O Research Group from the same university, the Research Institute IRIS-CC, 2 different hospitals. Then we have University of Manchester and Coco Health, which is a company, a digital company from England, and then we have Lithuanian Sports University from Lithuania. We have recently signed a collaboration agreement between these 3 countries. And here on the left, you can see the Coco Bladder logo. We received so far 3 sources of funding. The main one is from the Research Council of Lithuania. Then in Spain, we received 2, well, actually 4 sources of funding in total. 2 in Spain from Catalonia, 1, and the other one, 2 from the Catalan Board of Physiotherapists. And then recently, Coco Health also supported us to create a game. This is a research team. Maybe some new people is lacking, but because the team is growing. But as you can see, we are quite a few people involved in this ambitious work from the 3 countries. And recently, if you are a master's student or you want to get involved in a PhD, we have recently opened one PhD position, which is funded by Lithuania. And yeah, the applications will be this summer. So we are open to applications for this new post. This is for someone interested in academics, so to get involved with a PhD. To introduce the problem, urinary incontinence is a very bothersome condition, as you know. It affects more or less 36 million people in Europe. And the mean annual per capita cost of each patient is roughly between 300 and 600 euros per patient. The economic burden is also huge. Recently, we have data about this kind of submit, and it is calculated that half the medical cost of diabetes is the burden of urinary incontinence, and at least 2/3 the economic burden of cancer, which is huge. Also, it's projected that this situation won't improve. Unlike it will increase due to the increase of prevalence of urinary incontinence due to the aged population. And we also know recently research has shown that sedentary behavior is associated with urinary incontinence, especially in older women. We also know that a combination of behavioral therapies consisting of pelvic floor muscle training, so exercises, bladder training, and practical tips, all this combination is beneficial in the management of urinary incontinence. We also know that patients usually suffer from difficulties in access to treatment, long waiting list, feeling of embarrassment, etc. Also, systematic review has pointed out that new apps should focus on quality, evidence-based content, because most of the applications of the digital apps, they are not based on data, on real data or research, and also some features to increase adherence to treatment. As far as we know, there is no multi-component behavioral bladder health promotion apps with a self-management focus that targets end users. That means that has been co-created together with older adults and is evidence-based. So with all this situation, the main objectives of Coco Bladder are divided into two phases. The first one is maybe the most challenging, and we are now in this one, to co-create the solution. And the second one is to test it. So it's to test the e-health solution to battle or to improve urinary incontinence in adults aged 50 and over who are living in the community. We are building our Coco Bladder app based on a previous one, which is called Coco. This one is already available in Google Play, and this one is more focusing on prevention of falls, and Coco Bladder is focusing on bladder health. Which innovations we are going to target? The first one, we want to build the app based on behavioral change techniques. I'm going to chat later about this. Also, all the app is co-created together with experts, health professionals, stakeholders, and end users. We are going to use gamification, okay, using the Octalysis principles. Inclusive design, so we will be including audio, written, and visual instructions for older adults. Also, we want to create some kind of community so that the participants can communicate between them and also with a health professional. In the evaluation of the solution, we are going to include quantitative and qualitative methods. And if possible, we are not sure if we are going to be able to do it in this 3-year project, but in the next step, we want to include some kind of follow-up of professionals so that the health professionals can follow up the patients through the app. So phase 1 consists of these 4 components: a rapid review about what we already have on the market, which applications we have for older adults. We have finished this one. The second one, expert consultation. We already have interviewed 8 experts, and then 7 focus group, and we have conducted 3 so far. And also is very challenging this last part, which is to develop all the digital work with the solution. In the second phase, we are going to do a preliminary analysis of the results and then disseminate the results and the application. Yeah, we are going to use the Prosecco framework for the co-creation with the participants, and we are going to use quantitative and qualitative methods. So this is some kind of spoiler of the rapid review. This is submitted to a journal, and we are waiting for response. We did a rapid review in the 3 countries in PubMed and Google Play, and so not only in academic field, but also in the app market. So far, we found these applications, Bladder Boss in the UK, also TAT, which is created in Sweden, and urine control and urine for all, which is quite similar. So as you can see, we only have these 4 applications that are evidence-based, because we have more applications, quite a lot more, but these are the only ones that are evidence-based so far and are available at any of the 3 countries. So we did some kind of benchmark. In the consultation of experts, we use some kind of a script of questions. So, for example, existing solutions that they know, recommendations for future app, how to use gamification, etc., etc. So we are analyzing this data. This was the first focus group conducted in Vic in Spain, with 11 participants. In all this focus group, we include stakeholders, health professionals, and end users. This was the second focus group conducted in Lleida, like 3 months ago. Yeah, as you can see, most of the participants are women, because we know that urinary incontinence and bladder symptoms are more common in women. However, we try always to engage some men. Also 2 weeks ago or 1 week ago, it was conducted the third focus group in Kaunas, Lithuania, with 5 professionals and 5 end users. So I'm going to spoil a little bit like the main things, but I don't have enough time to go into detail, but just some basic things. So regarding the technological solutions and examples, I'm going to present the results of the focus groups, the 3 focus groups, no, sorry, the 2 ones in Spain, because Lithuania is being transcribed, and then the experts consultation. So they know these 4 applications: Squeezy, which is not evidence-based, TAT, Bladder Boss, and urine control. These 3 already appeared in the rapid review. The key features should be reminders, for example, to do exercises, personalization. I think this was the number 1 topic, personalization, progress tracking, professional support, gamification, and integration with medical records. What needs a new application to be successful? Medical supervision, motivation, accessibility, content moderation, for example, if there is some kind of chat, interactive features, clear information, better timing of reminders, and integration with healthcare systems. Regarding which are the components that you think are important for a new app, the participants said educational videos, healthy lifestyle information, user testimonials, brief informative segments, which is also education, practical tips, education once more, pelvic floor muscle training, bladder retraining, fluid and diet management, habit awareness and modification, bowel health information, access to professional support, and information on treatment options. Regarding behavior change techniques, the ones more commented from the participants were reminders and notification, progress tracking, gamification, professional support, feedback and self-monitoring, goal setting, social support and accountability, and habit awareness training. I'm going to show you one example of educational content. We are very close to finish like the educational videos. So I'm going to only show you the first seconds. Well, the first versions will be in Spanish because we still need to translate them into Lithuanian and English. And this is only the first piloting video, so we need to improve it. But it's only so to have you to give you like an idea. So so from the participants' insights, we created 20 educational videos lasting between 1 and 3 minutes. So they are very short to try to capture the interest. So the first 4 are about understanding urinary incontinence. The second block is about lifestyle modifications for urinary incontinence prevention and management. The third floor is about pelvic floor muscle training. They are not exercises themselves. They are explaining how it works. Behavioral training techniques. So for example, urgency suppression strategies to try to improve the urgency symptom. Treatment options. And lastly, emotional and social aspects. Apart from this, we are creating 26 exercise videos with visual and audio instructions. I'm going to show you an example later. So, for example, we have 5 warm-up exercises, including respiratory and respiration and mobility. Then pelvic floor muscle training isolated, alone. So endurance, 2 of fast contraction, 3 exercises of maximum contractions, and then 2 lifts. And then we have a block which is more challenging, which is not only pelvic floor muscle training, but also combining with functional activities. For example, the NAC for stress urinary incontinence, or combining with a squat or a standing. And then we also have 3 exercises in quadruped position and supine position. With all these 26 exercises, we have created, probably we will create, because this is still under construction, 21 exercise programs lasting between 5 and 18 minutes, and with 5 levels from beginner 1 until advanced, so that so it can be individualized. I'm going to show you a first example, but I remind you that this is only preliminary and we will probably improve it.
Boca arriba, con las rodillas flexionadas. Vamos a trabajar la respiración diafragmática. Pon las manos sobre tu abdomen. Inhala profundamente por la nariz, inflando el abdomen. Exhala por la boca o la nariz, desinflando. Inhala, inflando el abdomen. Exhala, desinflando el abdomen. Inhala, inflando el abdomen. Exhala, desinflando.
I'm not sure if you are able to hear the audio, but anyway, it will be like audio instructions and also the script. Okay. Okay. We also asked the participants about gamification. They highlighted these aspects: levels and achievements, rewards, pelvic floor training games, bladder habit challenges, or social competitions. And right now we are working to organize, probably in July, 2 workshops to co-create this educational game. One workshop online with experts, and then one face-to-face in Manchester with end users. This is to get the insights in order to create a game that is more adapted to the end users. Regarding the technical features, the participants highlighted it should be user-friendly, personalized, integration with health records, some kind of cross-platform compatibility with Android, etc. That it can be also used offline with no internet. It can provide data analytics and feedback and secure data storage. Regarding barriers to adoption, the participants highlighted this one you can see on the screen. And also regarding adherence, which is also a common problem, people say some solutions can be using reminders and feedback, so behavior change techniques, once more, visualization, professional support, use of rewards and achievements, for example, with points or some kind of score, social features and regular progress updates. So we are in this red vertical line right now. We have finished the experts consultation, the 2 focus groups in Spain, and the first one, Lithuania. Now we are focusing on Manchester to do the workshops about the game, and then to conduct the first focus group in the UK. After this, we will finish all the initial focus group. We will further develop the digital solution, and we will let the participants try do a first pilot with no deep analysis, but only to try and then see their feedback in like second focus group. Like once they try the solution, we can do some iterations and improve the solution. At the end of the story, the intervention components of the first version of Cocoa Bladder, of course, we would like to improve it in the future, but with the funding we have right now, I think we are able to promise this. So the education videos that I presented, the exercise videos, for me, these 2 blocks are like essential for success. And then also social support through a community chat and the possibility of the participant to communicate with a professional. In the meantime, the professionals will be ourselves, so someone from the team. And we will coordinate all this with technical features, so with some kind of rewards, reminders. So we need to build like some technical features here too. After this phase 1 that we are planning to finish next year, in the beginning of next year, we will start phase 2, consisting of experimental testing phase. So we are going to test the solution in the 3 countries, compared to a control group that will receive no treatment. And we will see the preliminary results in 120 participants, 40 per country. So we are going to engage here people over 50, community dealing, so no institutionalized, people who is able to understand the national languages and use a laptop or a phone or a tablet, okay? And with a few exclusion criteria, very important, like red flag and unstable health conditions. We will measure the success with the ECIQSF, measure the severity of urinary incontinence, and we will be measuring several secondary outcomes. Apart from all of this, we are going to measure also physical activity through an accelerometer. And we will be including quantitative and qualitative measures. Well, the dissemination plan is quite ambitious, but thanks to the collaboration of the PhD students, and we will have three PhD students in October. Now we have 2, and we have submitted the first 2 papers. So we are starting working in the 3rd and the 4th. Okay, I'm finishing. This is a 3 years plan. So we are finishing the 1st year. We already have a web page, so I invited you to visit. It is still under construction, and hopefully the next months with a login, the participants will be able to enter here and see all the videos and everything. And if you have any doubts or you want to contact me, you can press here contact up right, and then I receive a message. And if you are a patient or you are from academia or a stakeholder or whatever, I'm open to collaboration here. Last month we opened an Instagram, so we have also Instagram account. Feel free to follow us. And that's all from my part. Thank you very much for your attention. If you have any doubts, you can use the chat and we will try to answer all your questions at the end of the webinar, okay? Okay, do we have Adrian here? Yeah. Adrian, how are you? Are you ready to continue?
Well, thank you. In fact, we're going to pair up as ever, and Bill's going to run the presentation for this webinar, and I'm going to chip in along.
As he does. Good morning, afternoon, whatever
Okay.
time. So I will share my screen. There we go. Can we see that?
He's thinking, I think it's coming. Okay, we can see it. Thank you.
Okay, awesome. So thank you very much. So my name is Bill Gibson. I'm a geriatrician at the University of Alberta in Canada. My colleague, Professor Wag, he and I often come as a pair. That's just the way it is, I'm afraid. So we've been asked to talk about care homes and why improving delivery in care homes is such a crucial factor when it comes to the interventions like COCU and like PROCON, which Javier is going to be talking about later on. Care homes are changing. If there's one thing that modern medicine is very good at, it's creating an awful lot of very old people. And as people age and as society ages, the same proportion of the population is being admitted to long-term care, meaning that as we get more and more complex and more people with more and more health concerns, those who are being looked after in the community are becoming more complex and more frail. And the very frailest of that group are being looked after in care homes, meaning that the people in care homes are now much more dependent, much more complex, and much more difficult to look after than they were 20, 30, or 40 years ago. So these are data from 2019, which is looking at the length of stay for people living in care homes. People who live in care homes are now going there very much towards the end of their life, and the median survival in long-term care is only 9 months. And the people who live in
Bill, and again, if you add in the effect of aging in place policies, you know, to defer nursing home placement, and the graph there shows the difference in Edmonton, where we are, and Winnipeg, which hasn't had such aging in place. You can see that slide down of lengths of stay, where you have active policies to keep people at home, which means those of us that do research in long-term care can now need to extend into that very dependent group of individuals receiving care in the community, because there's very much a blurring of those populations.
And as Adrian says, as a result of this and the societal change and policies to try and keep people out of institutions, people who are actually being admitted to long-term care, people who are moving to long-term care, tend to be older, they tend to have more ADL impairments, they're more likely to be cognitively impaired, and they are much more medically complex and take far more medications. So the group of people we're looking at when we're dealing with people living in facilities are very, very different to how they were a few years ago. One of the persistent concerns with long-term care is how they are staffed and who is working there. These are data from the Parkland Institute, who run care homes here in Canada. And they found in one survey that nearly half of their workers felt that they consistently lacked time to complete their required tasks. And only a quarter of them never had even essential tasks were completed at the end of their shift. So a quarter of people in the survey were reporting that on a regular basis, they were finishing their paid hours with outstanding work, which was essential for the well-being of their residents, which then led to 70% of them, nearly three quarters, staying beyond the end of their shift at least daily or once a week. A lot of care homes are run by private companies and for profit, and for-profit facilities, somewhat predictably, tend to provide less quality care, less direct care, and are more likely to have fewer staff. Clearly, if you're putting money into a system and taking some of that money out as profit, there is less money there to pay for the care. Adrian, you had a point.
Yeah, no, and certainly above the data from the States, you're quite right that private for-profit institutions, there are good evidence that the quality of care provided does not equate to that in public service. But also, additionally, there are good data to show that the private facilities almost cherry pick their residents, where if you're, certainly again in the States, black, poorer, obese, more disabled, you're more likely to be in a public facility than in a private facility. So lots of discrimination going there, and certainly things which have an implication for continence in care homes, where we see higher rates in the public sector than in some of the private homes, but very, very regional.
Yes, absolutely. The other thing that we find sort of experientially from an inpatient care perspective is if you have someone living with dementia in hospital and you're trying to discharge them to a new facility, the private living facilities are very keen to find good reasons that they can't serve these people's needs. And we'll talk about continence in a few minutes, but incontinence and having significant continence needs is often a reason for facilities to say, oh, it sounds like they're a bit too much for us to look after. And then it means that we have a concentrating effect of the most challenging people in this group, the people with the greatest needs, perhaps the people with the most challenging responsive behaviours, and the people with the most heavy continence needs are being cohorted into the same homes, leading to great disparities in quality. When you measure quality, often what you're looking at is outcomes rather than process, meaning that unless you're very careful to capture these data around who is going into the homes, what's the case mix, it's very easy for private homes to look very, very good. And the reason they look very good is they have a much easier job of it, and you need to be very careful to capture that data appropriately. Thinking about incontinence specifically, people who are living in long-term care have increasing continence needs. Apart from people with spinal cord injury, people with dementia living in long-term care have the highest prevalence of incontinence of any group in society, with reported prevalence between 60 and 90% of long-term care residents. And even if you are continent when you move into long-term care, you are likely to develop incontinence over your time in your long-term care stay. And if you have a dementia diagnosis, you develop a more rapid decline in both bladder and bowel incontinence than people living without a dementia diagnosis.
And that reflects intriguingly on the institution, doesn't it, Bill? Because there's a lovely paper around this idea of managing incontinence and the expectations of the staff, where a paper reported that the staff expected in older adults to become incontinent simply because of the institutionalization, and was matched by some older residents' expectations of retaining their continence upon institutionalization. And we know there are a lot of practices which don't actually support continence, but actually seem to support incontinence, and much as the routines in hospitals might encourage incontinence rather than continence. So again, another problem we need to address.
Yeah, and if you want to render an old person incontinent, put them in a facility to be looked after and guarantee that they'll be able to develop their incontinence nice and quickly by being placed in pads. And there's lots of reasons for this. Some of them are quite simple in terms of, if you need 2 people to transfer you and there are not 2 people to be available, you're not going to be able to maintain continence because you can't get to an appropriate facility. we have therefore a lot of new needs. You know, the landscape is changing, the population is changing, but the vast majority of our data on efficacy interventions for continence in long-term care is coming from the late 1900s. One of my residents described some music as being from the late 1900s to me the other week, and I've never felt so old in my entire life.
Yeah, that's a mistake. I suppose 1900s. There should be 1990s. And it's right. It's a long way out. Made it rather extreme. That
it is the late 1900s.
It is
it's
true, but
not
yes,
a mistake. It's
a big gap.
Afraid to say we are from our era is in the last century, and such is life. It's creeping over here. I'll be needing reading glasses any moment. So time voiding is the practice for people living with dementia in facilities where you ignore their normal bladder habits completely, and sort of every 90 minutes or every 2 hours you encourage people to toilet. That was published in 1986. You know, nearly 40 years ago now. And prompted voiding, which is where you pay more attention to someone's normal bladder habits. You look for the signs and the clues that people may need to void, and then you use assistance and positive reinforcement for successful toileting to try and improve bladder habits. That was reported in 1993. So these are 30, 40-year-old data, 30 or 40-year-old practices, but are still the most common ways of managing incontinence in long-term care. There are some interventions which are, well, it's fair to say that we with this increasingly complex population and with an increasing knowledge of continence care and how it can be delivered, we need more nuanced, more multifaceted and more targeted intervention. These have some evidence of efficacy, and there's a lot of work that Javier is going to be talking about the work that we're trying to do as part of our group to improve this. But the evidence is currently lacking, and it is not there yet, and certainly the uptake of these interventions is not there. The most common intervention is check and change, where you just allow someone to have contained incontinence into a pad, and then on a time basis that the staff in the home will just check whether or not someone needs a fresh pad putting on. This can be effective in terms of skin health, in terms of keeping them socially dry and avoiding wetting their clothes, but it's not particularly dignified, it's not particularly comfortable, and given a choice, wouldn't be what most people would want in late life. And there's also the issue that we can put in place all these lovely plans, and we can have a beautifully documented care plan for, you know, when Mrs. Smith is going to be taken to the toilet and when she's going to receive continence care. But, you know, all great plans survive until contact with the enemy, and what is actually delivered to residents is often not what is written down in the plan.
Yeah, well, as you said, Bill, that the problem that we face is incontinence is the result of often a multifactorial combination of things wrong. And the multifaceted interventions which are undoubtedly required are very few have been tested. There are some which combine prompted voiding, exercise and nutrition in care homes, which have found to be effective, but you need a mobile, fairly cognitively intact individual to do that. And those, as you rightly say now, where 70% have Alzheimer's disease or related dementias in care homes, becomes a minority. And likewise, a minority are really eligible for prompted voiding per se. Hence, check and change becomes the most common thing. And you mentioned toileting, and we found in recent care home work that the care aides often called resident toileting, taking the resident to the washroom and changing their pad. Nothing to do with actually what we might term successful toileting in the true meaning of the word. And I know you've done some work on people's nuanced understanding of the word toileting, and perhaps you'd like to share a bit of that, because it was really quite interesting.
Yes, so we my group has a paper at the ICS conference in Abu Dhabi that we're presenting, where we were having a conversation. It was around this kind of work. Adrian and I were chatting, and we both kind of knew what toileting meant, and then we tried to define it, and sort of very quickly ran into all sorts of problems as to what the term toileting actually means. So we've done some work where we pulled as many papers as we could, which used the phrase toileting, and then extracted from those papers what the authors used toileting to mean and how they defined it. And we found a huge variation in understanding of the term. So for some people, toileting was any intervention that involved continence care. Some people, toileting was very specifically taking someone to a toilet to use a toilet and cleaning them up afterwards. And then you ask yourself, well, when I went for a pee this morning, was that toileting, or is that just a normal activity of my daily living? So there's a lot of nuance around it. And from a research perspective, we're publishing work where we say we're looking at toileting, but until you define what you mean by that, you can't actually reproduce or really interpret those data. The other thing to think about with these multifaceted interventions is that many of them have good evidence of effect, but their evidence of efficacy is much less good. Meaning, when you've got a research team coming in every week and you've got a lead research nurse coming in to drive things forward, you've got the dedicated team, you've got lots of attention, these interventions work really well. But then the research team leaves, you're left with the same staffing and the same home, and rapidly things go back to normal and the intervention is lost purely because there isn't the ability to maintain.
Yeah, so and a great example is the recent study where simply focusing on continence even in the usual care group had a huge impact on improvement of care delivery, with changing nothing else. You're quite right. But as you say, good evidence to show that prompted voiding is unsustainable with current levels of staffing.
Yeah. So maybe there's some new technology that can help. This is a paper which Adrian was the lead author on, looking at a smart pad. So this is if you think back to the old Bellum pads that we used to use for nocturnal enuresis in children for Mauer's conditioning. Basically, it's it's an alarm connected to a broken wire, and when salty fluid, i.e. urine, touches the wire, it completes the circuit and sounds an alarm. This is still the mainstay of treatment for kids with nocturnal enuresis. It wakes them up at the time of an episode of incontinence. But this company have developed a continence brief which has this kind of technology embedded and sends a Bluetooth message to a device. So basically, the pad will text the care aide to let them know that someone needs changing. This was a trial looking at this smart urinary continence care assessment in nursing home residents, which found that there was a significant change in the number of residents who achieved 24-hour reduction in pad absorbency, down from 50% to 40%, and differences between group changes in total absorbency of pads. So by using these smart pads, people were having less full pads and were able to be changed in a more targeted and effective manner. Is there any nuance of that interpretation I've missed there, Adrian?
So I think the number of pads at night, less disturbed sleep, was one really useful outcome. And this system was used for 3 days to construct a preemptive pad change program, and the use of this was then the care program from this initial assessment was then used sustainably up to 6 months later. And the interesting thing was that the care aides and the staff on the ground used their use of this and the plans generated as evidence to family caregivers that they were taking continence seriously. And this is the evidence they had to show that they were doing that. So the qualitative work which followed on from this study showed a lot of more subtle, soft effects of using this kind of technology. And it may actually aid person-centered care in the delivery of continence care.
Yeah. The issue, of course, is that these pads are significantly more expensive than a dumb pad. And I think we talked to Adrian about the some homes, particularly the private homes, were using this as a sort of, like you say, a quality marker, almost an advertising, to say, look, we use this great technology to make sure we're keeping your mum dry.
Yeah, and of course the elephant in the room is fecal incontinence. These things, the idea is you get better check and change for saturation, but of course fecal incontinence doesn't trigger saturation, and we don't want people left in fecal soiling for very long at all. We know that residents don't want it, and we know that it increases the incidence of incontinence-associated dermatitis. So that's a big problem with these technological applications, really centered around urine. And so in the studies, you will find that people with significant degrees of fecal incontinence are excluded.
Yeah, and fecal incontinence is a real problem for all sorts of reasons. Even the sort of standard pads are just not designed to contain feces or keep skin safe from feces, and there's a huge technological gap in terms of effective collection devices for people with intractable fecal incontinence. So why do we find it difficult to make things different? So lots and lots of barriers to improvement, and making any kind of change is very difficult. And you can think about the difficulties in introducing change and introducing new interventions in facilities on sort of the level of the individual practitioner and staff member, of the organisation and society as large. This paper from 2023 was a review article which said very, very blithely in its conclusion that nurses are inherently conservative, which I thought was a slightly pejorative term, but not unreasonable, in that every professional is often very, very conservative, and people have a great belief in what we do and how we do it, and making people change is often very, very difficult, purely because people like the familiar. There's also the thing called the hidden curriculum. Hidden curriculums are concepts in education where we can lay out what we're going to teach our students and teach our learners, but what they actually learn is largely based on culture and practice and, quote, how we do things here. And that is often not written down, and finding out what is being taught to new staff members about how we manage incontinence is very important, because, like I said before, toileting schedules are all well and good, but what really happens to residents when they're being looked after is often very, very different. On organisational levels, there's again this very embedded culture of how things are done and how staff work, but organisations are often very risk averse and fear litigation. And it's much safer to do what we've always done and say, well, that's how we do things. But making change comes with risk, and people often feel, from a managerial perspective, will feel that if they try something new and something goes wrong, that is going to be a terrible thing, and they will get in all kinds of legal trouble, and they'll get sued, and it's all terrible, and there'll be bad publicity. Whereas if things are as they are, then they've been getting away with that, so they don't need to worry about how that's going. And there's also the problem, of course, that any change usually comes with upfront costs, even if there are significant cost savings down the line. You need to sort of prime the pump and start off by saying, okay, if we increase the staffing levels, we'll have fewer falls, fewer episodes of incontinence, fewer incontinence related injuries, and less incontinence associated dermatitis. That will save money in 5 years' time, but right now we need to pay out more, and that becomes a huge barrier. And then on society, we are professionals who love to talk about incontinence. This is why Adrian and I don't get invited to many parties. But as in general, we don't tend to talk about continence care. We don't talk about bathrooms. We don't talk about fecal incontinence. We don't talk about containment products. It's a very hidden and taboo subject, and it's not glamorous research. The cardiologist can invent some new antiplatelet that's exactly the same as every other antiplatelet, and everyone fawns over them, throws billions of dollars of research funding. Javier moved heaven and earth to get his research funding, because it's very, very difficult to persuade funding bodies that this is a group of people who either deserve good care, deserve research, and that we should be looking at continence care and incontinent old people. And again, society is, taxpayers don't like paying tax, and finding efficiency, whatever that means, cutting the cost of long-term care is often very important for our political leaders, and therefore these sort of interventions, which require upfront cost and often increased staffing, are very difficult to swing past in the current funding environment. Finally, we also have to define what we mean by quality. Quality can be sort of provider defined. People say, yeah, this is good quality care, and this is care that I provide, or it can be defined by guidelines. Guidelines, of course, are often not written with the complex, the frail, the multimorbid, and the difficulty in mind. People who write guidelines like to look at nice, simple, clean solutions where they can just concentrate on one problem. And there's very limited information, particularly on people in long-term care or people living with dementia, about what quality care actually looks like for them. So there is ongoing research from our group and others looking at, what is important for people in the later stages of their life, when they're living with dementia, when they're living in congregate living and long-term care facilities, as to how do they want to be looked after, and working that out, knowing what would count as being quality care for these people, allows us to measure what is actually important rather than what is just merely easy to measure.
So interestingly, having just now completed the scoping review according to the protocol, we found 14 papers which looked at this at all in the literature. only 2 concentrated on older adults in receipt of home care services, and the rest were in nursing residence. And what it's done is given us a framework of the kind of things that older adults were saying from the limited data to go on and do the qualitative work which is going on at the moment, both in Canada and in Sweden, with our group at the University of Gothenburg. And those interviews are actually proving very fruitful. The difficulty is getting to older women with long-term care. Again, most of the extant literature is women. There's a great need for work in frail older men, a huge gap. And again, that's being addressed by one of my PhD students, looking at factors important to older men that they're prepared to have a go at in terms of self-management. Obviously, the majority of the literature there is post-prostatectomy incontinence, neglecting that most men are referred to urology with storage, lower urinary tract symptoms, and not problems with voiding. So there's a lot to do, Bill, basically. We're just scratching the surface.
Yeah, an awful lot to do. If you want a long and fruitful research career, let us know, because there's a huge.
Yes, and hopefully you'll hear a bit more about Procon in a minute. It's taking several of those elements together, culminating in a locally adapted intervention, which is we're going to drive with frontline care teams to see if we can use all those great bits of implementation science to master some of those barriers that Bill described in terms of the organizational and systematic operation of care homes. Thank you.
Thank you.
Thank you very much, Bill and Adrian, for this super nice presentation. And I'm very curious to see the results of the quality scoping review. So yeah, so let's move forward to the last presentation from Hannelore Strauben. Hannelore works in the KU Leuven, so she's part of the Procon project, and she's going to present this new initiative. Thank you very much, Hannelore.
Yes, I'm still trying to check whether everything is okay. So you should see my slides at the moment, right?
Right.
Okay. So yeah, I will be the last presenter of this webinar, talking about the project Procon, which is a project where the previous speakers are also partners in. I am Hannelore Strauben from KU Leuven, from the Faculty of Engineering Technology, where I am a postdoctoral researcher at the moment. So some general information about the project is that it is an European project under the Erasmus Plus Partnerships for Innovation and Alliances. It has a duration of 3 years or 36 months, and the budget is more or less 1.5 million euros. And when you think about the project, about key areas or keywords related to this project, it is about innovation, continence, entrepreneurship, technology, elderly care, and nursing homes. So Javier already gave some urinary incontinence facts and figures, so I'm not going over them again here. So indeed, we know that many people suffer from incontinence. There is a high cost related to incontinence as well, which is expected to increase when nothing happens or is changing. Maybe something that was not discussed yet is the fact that there is also an ecological part when we think about incontinence, being the waste of incontinence material. And here, if we would be able to recycle 100% of all the materials, we could decrease the carbon emission with 1 billion kilogram by 2030. So it's the impact is also quite huge there. So in addition to these presenters here today, we have other partners as well, 13 in total. They are from different countries, being Belgium, Spain, and Canada, but also Finland and Italy. The main and primary objective of our project is to foster innovation in nursing homes, specifically in the promotion of continence in nursing home residents through the cooperation and flow of knowledge. We want to obtain this objective with several key activities. where this project is a collaboration between academia and industry in innovation and entrepreneurship. We are looking into technologies to support continence care. We also want to develop training and education for healthcare professionals and students, but also for nursing home residents and their informal caregivers. Especially this training and education will also be evaluated in an international pragmatic study that will be conducted in 4 different countries. And we also try to create or develop a digital space with virtual communities of practice. What is the final goal or some project outcomes that we want to have in the next couple years? So we want to develop a framework on innovation and entrepreneurship that should include recommendations for healthcare and nursing homes. Then we also want to look into technology that can be used to support continence care in nursing homes. And we are looking more into the sensor data, which can give more objective information when looking into incontinence profiles from the residents. We are also developing different courses, 3 specifically, one on innovation and entrepreneurship, another one on resilience skills and flexible work practices, and then a last one on continence care. And as already said, these courses, we will also evaluate their feasibility and effectiveness through a pragmatic study in the nursing homes in different countries. And at last, we also develop a toolkit, which will be the education for the nursing home residents and their informal care partners. The expected impact with this project, so we aim to improve the quality of life for the nursing home residents, but we also want to reduce the burden on healthcare staff. Then we aim also to lower healthcare costs by integrating new practices on continence care, but also by looking into technological solutions. Then the last part. So we also want to introduce these innovative technological solutions to support continence care. So the project is now in the first year, so we do not have that many output yet. But with regard to work package 2, we were happy to submit the first deliverable on the framework. So in work package 2 from the project, which is about innovation, technology, and entrepreneurship, we want to foster this innovation and entrepreneurship in healthcare and nursing homes through the co-creation and knowledge transfer between academic institutions and stakeholders. So when we look into the framework, we had 4 national workshops in Spain, Belgium, Canada, and Finland, where we asked the workshop participants to discuss good practices on entrepreneurship and innovation for the first part. And then the second part was on Geron technology, green aspects, sustainable development, and resilience skills. The participants were a variety of people, being students, but also experts or researchers in the field, stakeholders from nursing homes. This can be nursing home directors, but also policymakers, nursing home staff, and business professionals. During this workshop, we also used the EntreComp framework. This is a framework from Europe. EntreComp stands for Entrepreneurial Competences. And so we used this flower that you can see on the right to think about the good practices for our own framework. The workshop was conducted via a turning tables method, which is coming from the GPS brainstorm method. And for each turning table workshop, we had 6 teams on a central table. And in the first phase, participants could generate IDs in pairs. This took 3 to 8 minutes, and the IDs were written on sticky notes. Then we selected IDs individual via dot voting. So each participant received 8 dots to vote for preferred IDs, and also 1 veto dot to say like to vote for an ID that they really disliked. Then at last, we ranked the IDs and looked into the motivation. This was conducted in group, and from this discussion, we then made a top 10 of the most promising IDs and lists of vetoed IDs as well. So what you saw here was first the sticky note clustering, voting, and group discussion. Then a thematic analysis was conducted of the collected data across all countries. This was then also integrated with the result. The results were integrated with also the Entrecomp guide and flower that we used during the workshop. And this then generated our deliverable, which is publicly accessible. This framework was very important, or is still very important in the project, because it will guide the creation of all future courses and solutions in the project. To be more specifically, we have a figure for this as well. So this framework, in the first part, we have the technology and the course on innovation and entrepreneurship, where we will look to the recommendations to make and choose the technology or the course content. And then on the other part, we have the course on resilience and flexible work practice, but also the continence care in nursing home course. So here as well, we can use our framework to create the content needed for these courses. One last thing I want to share with you is one of the results. So this is part of our framework. So when we combined all the results from all countries, we made a kind of a metro map where we bundled all the recommendations on innovation and entrepreneurship in nursing homes. You can also still see the different aspects of the Entrecomp flower, being the resources, the into action, and ideas and opportunities part. And when we then, for example, look at the ethical and sustainable thinking metro line, we here see 2 recommendations, being the fact that we want it to be resident-centered, so we want to use person-centered values, and the resident needs to guide innovation. And then another part is to value the alignment. So innovation should be guided with long-term values and also ethical principles. Another part, as an example, is the motivation and perseverance in the resources. Here, for example, you have the recommendation to sustain innovation, which means that we want to ensure structured follow-up for sustainable innovations. And the stay committed is that we recommend to promote resilience and commitment when innovation is at some part difficult as well. A last thing that I want to mention to you is our educational toolkit that we are developing in work package 6 of the project, because here the main goal is to develop this resource for older adults living in the nursing home and their informal care partners. It will be tailored to address their questions, to also enhance their knowledge and experience, and improve the outcomes that they consider most important in managing urinary incontinence. And this toolkit will be developed via an international multicentric study, where we will gather information both from the nursing home residents with or without the lived experience of urinary incontinence, as well as from their informal care partners. So the toolkit is not here yet. So if you are interested in this outcome, but also other project outcomes, you can always follow us at Instagram, but we do also have a project website that you can see the link at the bottom, procomproject.eu. And nowadays you can also find us on LinkedIn too. So here I want to close the presentation and thank you for your attention. If you want more information on the project, follow us on the platforms, but you can also always contact one of the speakers today or the principal investigator, being Javier.
Okay, thank you very much, Hannelore, for your nice presentation. So we have finished the 4 speeches. We are open to questions now. I don't see any question in the chat, but you can activate your microphones now and you can speak any of the attendees. People is shy. Okay. So in the meantime, I have a question for Bill. Bill, are you here? Yeah. Thank you. So I was curious about the quality care measures after the scoping review. Are you planning some kind of next steps or Delphi study or consensus or whatever, like to have like a framework? Because we know that it's like we are trying to define in Procon like what is quality continence care, and we are having a lot of discussions which are the main outcomes here. So is the resident perspectives, is the reduction of leakage, which is quite quantitative and basic. So which are your next steps here?
So the scoping review is Adrian's work rather than mine. And the point of a scoping review, of course, is to map what we know, but more importantly, identify what we don't know. And a scoping review should really be an agenda setting exercise. So I would suspect that once the scoping review is complete, and Adrian mentioned there were only 2 papers, I think you said, which looked at the perspectives of service receivers from long-term care. You know, there's going to generate an awful lot of questions. You're on mute, Adrian.
12 in long-term care, 2 in home care.
Oh, okay. Sorry,
yeah.
wrong way around.
So what that's given us, Bill, is a, if you like, a thematic framework on which to develop some qualitative work with residents of long-term care and with older women in receipt of home care. And we've defined them as requiring help with personal care on at least 3 times a week to really try and get the perspective as those more dependent individuals. The framework has maybe unsurprisingly defined some elements of dignity, preservation of self, autonomy, some desire for shared decision making. And again, of course, this study is limited because nursing home residents have to be cognitively able to engage in the work. But the end product is going to be, we hope, a balanced scorecard by which we can guide continence interventions for dependent older adults. With those things in mind, previous work we've done with Joan Ostaskiewicz and with Jenny Billings around preservation of dignity, it's incredibly difficult to measure. Older adults are happy to tell you where dignity has been violated, but then to say, well, okay, what is dignity preserving care from the perspective of older adults has been very, very difficult to get to and to objectify such that you can measure it. But by the end of this process, and we're currently doing the interviews both in Canada and Sweden, we hope to have a balanced scorecard. And as I think we've mentioned as part of Procon, this work will be really quite informative when we think about interventions. Interventions come from the perspective of the care provider. There is plentiful work in continence care of what is quality continence care from the perspective of the provider, and that doesn't always align. Often defined by guidelines, following guidelines is good quality care. Not always the case. There's a great study from the States where female reconstructive surgeons and urogynecologists went to older women in one particular veterans home, talked to the women about having regular reviews of their pelvic floor disorders. And essentially the women said, we don't want any of that. We want dignity preserving care, which allows us to preserve self and hides our incontinence. Thank you very much. So a great mismatch. When we know, sorry to bang on, from our work in people at end of life, they will say, give me a catheter. That solves my problem. No guideline will say, give me a catheter because of the complication risk. And these are people not in imminent risk of death, but death is foreseeable. I don't want to be bothered about my continence. I just want to get on with the life I've got and don't want to engage in all of this. So things that we wouldn't consider guideline directed are wanted by people in the situation. Sorry,
and there's the fundamental problem that continence care is inherently undignified. You know, if someone is living with incontinence and requires assistance to manage that, that is, you know, de facto an unpleasant and inherently undignified situation to be in. And there are things that we can do to maximize dignity, but you know, we can't let perfection be the enemy of the good here. And it's very difficult to say, you know, we want things to be absolutely perfect in this very complex group of people with disparate and challenging needs who are, you know, needing an awful lot of looking after with an awful lot of things.
Thank you very much. Adrian, you mentioned catheterization, and in Procon, we recently finished the focus group asking nursing home staff and the students from bed providers and higher education institutions what they want to learn about continence care in nursing homes. And as you remember, one of the multiple topics they want to learn is catheterization and how to do it well. What do you think about catheterization in long-term care?
I think that ideally catheterization should be something which you consider very carefully for incontinence in frail, dependent older residents. It should be avoided. Intermittent catheterization would be eminently preferable if one can do it. But very occasionally, it's a pragmatic solution to a problem, but it has to be thought through. And often it becomes a almost reflex response to a problem without thinking of the alternatives. And yes, I think Procon, the course we produce, should be relevant and contextualized to residents. I remember my great aunt who entered a residential home, became less mobile, had a catheter chucked in, died of urosepsis. There was no attempt at regain of mobility, for example. We know that mobility is a huge factor in development of incontinence. Sorry, Bill.
And often people who are in whom we use a catheter for continence care really like it up until they get the infection and end up in hospital, and then they realize it was a bad idea. But if someone has incontinence which is difficult to manage, a catheter keeps them perfectly dry, and in the immediate, you know, short term, solves their problem and is great. And often people you see in clinic say, you know, why can't I just have a catheter? And then you say, well, because it will probably kill you. And then they decide that they'd rather not. But it's very easy, like Adrian says, happened to my wife's grandmother. She had a catheter put in because she had incontinence. No one ever, you know, talked to her about why she was incontinent or tried to treat it. And then when I had one of my rare but fun rants at her family doctor, it got sorted and a catheter came out. But she had several infections and was very unwell with it. But at no point did anyone say, you know, this might not be the best of ideas. Because in the short term, solve the problem.
So it should be like the last option. And what do you think about these new external devices? Do you know what I mean? Yeah.
Yeah, so again, I'm doing some work on those. They have, I think, good evidence for short-term use. Their motivations to avoid catheter-associated UTI. The data are actually not that good. They are being posited for longer-term use. I think they are quite efficient in urine collection. The cost, of course, is considerable. And again, for very dependent individuals with double incontinence, they can't cope with fecal incontinence. So you're left with a pad anyway, which is then much cheaper. But for short-term use in, for example, preoperative use for those with extensive burns, they're a good way of avoiding indwelling catheterization. And I must go. Sorry, excuse me. Thank you, everybody.
And for people for whom they work, they're really good. The problem is with the PureWick, the body-worn female catheter with condom catheters for men. In people for whom they work very well. But for the majority of people, you can't get them to fit properly. They fall off, they move, they fail. So again, continence care is always a very very individualized, very complex issue, and there isn't a helpful sort of one size fits all. Andrea asks, what external devices are we talking about here? So there's a few body-worn containment devices on the market. So I think the one Javier's talking about is a thing called the PureWick catheter. which is basically like a straw looking device that sort of suctions onto the female perineum and has a very gentle suction attached to it. So incontinence is collected into a tube and then into a bag, but doesn't actually have anything indwelling. So it's not an indwelling catheter, so there's less infection risk.
Yeah, it is quite new. Thank you, Bill. So any more questions in the chat? We have some questions from Andrea. Maybe Hannelore, Bill, and me, we can answer the first one. What inspiration can we have from previous research? Well, inspiration, I feel very inspired by Adrian and Bill's work from Canada, also from Hannelore. I really like her research too. Also from Australia, this Joanne Ostalwitz and other researchers. I don't know if you refer to people or to research lines, not sure.
Yeah, I think basically our new project now, Procon, is like the combination of everything that we, like the inspiration that we took from previous research, from our own research at least, to put it in a new project that we are now doing together.
Yeah, for me, it's like combining innovation with training, and so it's like a mix. It's not only research; it involves also education and training and entrepreneurship. Yeah. So we have a new question in the chat. How do you manage the patient recruitment for Goku Bladder project participation? Yeah, this is a good one. Mainly with two strategies. The first one is with contacts. So we have contacts with healthcare providers. For example, in Spain, we have a nice collaboration with two hospitals, one hospital in Vic, another one in Lleida. Indeed, one PhD student works in the Lleida hospital, which facilitates a lot. And then I have good collaborators, gynecologists in the hospital of Vic. And for example, here in Manchester, where I am currently, we are now engaging healthcare providers too. And in Lithuania, it's the same. So this is one way. And the second way is through social media, this kind of webinars we are doing now. So social media, and yeah. And so far is, to be honest, so people is quite interested. So we haven't started like the recruitment for the pilot, so the piloting phase, but so far we haven't got big issues with recruitment. So people is quite interested in participating. Yeah, thanks for the question. Any other one?
Maybe something that I was thinking about when Bill and Adrian were doing their talk. So you mentioned that indeed, it's more like a comment. I don't really have a specific question, but for America, it is like the residents that have higher care needs in private nursing homes, they don't really like to take them in. But in Belgium, it's actually a bit the way around, because we get finances depending on the care needs of the residents. So it's also interesting to see how it is different between countries or regions actually.
Yeah, and these are very sort of political decisions, aren't they? The systems are set up very differently. You know, in the States, it's a lot of what we would describe as long-term care facilities are much more kind of, you know, assisted living, or even just sort of, you know, seniors apartments where people are largely independent, and whereas, you know, the public system is then required to take those people that need, you know, have nursing needs and have more complex needs, like you say, in more, would it be fair to say forward-thinking countries, and you know, more sort of liberal European focused places, much more set up to meet the needs of the people who are there. And in the UK, there's huge problems because the whole system was set up after the Second World War. There were two big acts of parliament. There was the National Health Services Act and the National Assistance Act. So the National Health Service Act created the healthcare system, and then the Assistance Act created the residential care system. And those two things are completely separate. So you then end up in huge amounts of sort of financial arguments, because if your needs are personal, then that's paid for by the city, whereas if your needs are healthcare, it's paid for by the healthcare system. So those two people just end up arguing with each other about whether or not, you know, continence care is a sort of a personal care need or whether it's a healthcare need. So feeding into that from a researcher perspective and from a clinician perspective, it becomes very difficult, because you're coming at it from a completely different lens to the people who actually make the decisions, and sort of the advocacy is really important, and making sure that we don't lose track of what's actually important, which is, you know, looking after people and meeting people's needs.
Thank you very much. We have still like 5 minutes if you want to comment something. No. Okay, so thank you very much for everyone. I really enjoyed the discussions. It was very interesting. Thank you very much for your attention, and yeah, see you soon. Thank you.
Thank you. Bye.